one of the common themes among several of these is plural related, that's one of our topics that's coming, is the plural related disorders. And another one is mediastinum. Mediastinum, diaphragm, and pleura are kind of three little chapters we kind of look at all together, and we have a couple examples of mediastinal and some examples of plural related things. So if we look at this one here, this is two different patients both having difficulty breathing. I suspect this one's going to be in worse shape though than this one. So the common denominator among both radiographs is very bright density, right? Mm-hmm. Unilateral, and pretty close to homogeneous opacification of an entire hemithorax, isn't it? On this one, the whole thing is very white looking. This one, the whole thing's very white looking, but there's a difference in which way the mediastinum is going, isn't there?
Yeah.
On this one, trachea is here. Heart borders halfway into the right lung, which would suggest to us the mediastinum is being what? Pushed. It's being pushed by something that's likely getting bigger and expanding. It's just pushing out of the way, isn't it? Whereas the trachea on this one is over here instead of here, which means the trachea is going toward an increase in density, isn't it? And this is a great example of the difference. Mediastinum away, mediastinum toward. And we know that when anatomy moves toward, what's happening?
Atelectasis.
Losing volume, exactly. We've got something that's causing atelectasis. And this is probably not lobar, it's probably the entire lung, isn't it?
Mm-hmm.
Because the opacification is the whole entire hemithorax. And there's no fissure movement visible because if you lose the whole lung, the whole thing collapses. The fissures just kind of shrink up with it. They don't really move any direction because there's nothing to overinflate around it. The whole lung is collapsing. This patient was an asthmatic and collapsing the entire right lung. This one is a heroin addict trying to inject left subclavian up here,
And she punctured the pleura.
and they went right into the pleural space, and of course inoculated the pleura because they use real sterile needles all the time. And now they have a massive infection going on in the pleural space. Yeah. This is called empyema, when you have a massive suppurative infection in the pleural space. So it means that most of this hemithorax is full of pus, exactly. And lots. There's a lot of it because it's going to collapse the lung also, isn't it? See, this does the same thing to the lung that pneumothorax does. It's just a different material. It's a liquid instead of air, but it's doing the same thing to the lung. It's compressing the lung. But because it's a liquid, it silhouettes the lung and you can't see it. Like you can with a pneumothorax, you can see it real easily because very different density. So this is a massive amount of exudate in there, and it's got weight to it. Unlike air, which doesn't have much weight. And so it's going to actually push the diaphragm down. It's kind of like set a gallon of milk on the diaphragm, the thing's going to go almost inverted. So it means the diaphragm's probably down here, which means you have even more space in there. But it's treated the same way. This has to get out of there. The pleura can't absorb that kind of volume. It basically has to get sucked out.
Is that a common injection site?
They try anywhere. Anywhere where they can hit a vessel.
Obviously, the entire procedure is pretty risky in general, but I feel like that would be even more so.
Well, I mean, they get pretty good at injecting because they do it all the time. Heroin addicts. So, you know, they're just trying to hit anywhere where they can get them. Unfortunately, this had a bad result. But it's a good example of anatomy toward or anatomy away from an increasing density.
And that resulted to chiropractic office?
No. These are from the path file. I have seen pleural effusions though, and I have seen some fairly large pleural effusions in chiropractic offices. Yeah.
But that was just from
These weren't, but I have seen some big effusions show up. So let's look at this one. This one is a little bit more kind of characteristic of what a pleural effusion can look like. And it also illustrates how lousy a film the PA view is for pleural effusion. A liquid in the pleural space is going to be influenced by gravity. So gravity is going to pull a liquid to the bottom, isn't it? It's going to go to the lowest point generally. And so what's the lowest point in the chest? Upright. It's costophrenic angle, but which ones?
The posterior,
Yeah,
actually.
because the diaphragm sits on an angle like this. So you have anterior, lateral, and posterior angles. And the posterior are the lowest point in the chest. That's called the dependent portion of the chest. So when you're upright, it's the posterior costophrenic angles. When you do a lateral decubitus view, it's the lateral chest wall of the side down, isn't it? If they're standing on their head, it's the apex. That's the most dependent portion of the chest. So liquid generally is pulled to the bottom. Now, there's some atypical ways that pleural fluid presents, but the typical way is gravity pulls it to the bottom. But there's the lateral angles. The posterior angles are down here. So on a PA view, you can't see a pleural effusion until it gets up high enough to start spilling over into the lateral angles. That can take 300 to 500 milliliters. That's a 500 milliliter water bottle. It can take that much in the posterior costophrenic angle before you can see it. So the PA view is not very sensitive. In fact, is not sensitive at all for pleural effusion. But if you look back here, you see how there's some density here? And notice what this does. Do you see how this curves up the chest wall?
Yeah.
That's called a meniscus. And the meniscus is what happens when you have a liquid in the pleural space because there's no air. You can't have an air fluid level unless they also have a pneumothorax with the hydrothorax. Otherwise, you get a meniscus. It's the same thing water does at the edge of the glass. You know, capillary action goes up the edge of the glass slightly. Remember that from chemistry or physics? The same thing happens. The negative pressure in the pleural space pulls the fluid up the side of the chest wall. So they get a meniscus is what it's called. It's very characteristic of a pleural effusion, meniscus sign. And if that fluid is really, it's not real thick, it would be what we would call kind of a low viscosity, it's real kind of watery, it can actually get pulled almost all the way to the apex sometimes. It can literally get sucked all the way up the chest wall, but it'll be very smooth. Unlike mesothelioma, which will be lumpy. And of course, pleural effusions commonly happen with mesotheliomas. But this is not visible on the PA view, it's only visible on the lateral, because there wasn't enough fluid to get over here into the costophrenic angles to be visible. 300 to 500 milliliters before it's visible on a PA. It's the least sensitive film for pleural effusion, the PA view. Okay?